Greetings, everyone. My name is Dr. Supratik Bhattacharya, and today it's an absolute pride and pleasure to have with us Dr. Neeta Despande. Dr. Neeta, MD FRCP Edinburgh and post-graduation endo from London, ASBP obesity certified from USA, and he's the senior consultant diabetologist and bariatric physician. She's also the director of Belgaum Diabetes Center Watch Children's Diabetes Center. She's a professor and head of the Department of Medicine, Dental College, Belgaum, and also associate professor of medicine, USM Kelly International Medical Program. She has several presentations on obesity and diabetes in national and international meetings. She's done publications in peer-reviewed journals and textbooks. She's been the past chairman of Karnataka RSSDI, principal investigator for several clinical trials, KRSSDI oration for 2016. She received the RSSDI fellowship in 2016 and FRCP Edinburgh, December 2016. She has been the coordinator of the Consensus Group RSSDI ESI Clinical Practice Recommendations for Type 2 Diabetes 2020. And she is a close personal friend as well. So it's once again an absolute privilege to introduce to you to Dr. Neeta Despande.
Thank you so much, Dr. Bhattacharya. And today, I should thank the organizers also for giving me this opportunity to speak about this molecule and this class of drugs in particular, which is the rage now. And I would say, I wouldn't be wrong if I said that it's the molecule of the century, actually speaking. And I shall launch into certain aspects of it, especially about the heart failure aspect, which is being talked about now a lot with respect to diabetes and otherwise also. So here we're going to talk about diabetes, heart failure, and dapagliflozin. Well, just to give you an introduction of the connection between heart failure and type 2 diabetes, let's first look at the burden of heart failure in type 2 diabetes patients. We all know that diabetes increases the risk of heart failure twice in men, twofold, but fivefold in women. And the term diabetic cardiomyopathy, which is basically heart failure, was coined 40 years ago. So in general, we know now that patients with diabetes mellitus are at greater risk of developing heart failure than their counterparts without diabetes, and the risk is at least twice those of non-diabetic individuals, which is considerable. If you had to look at why this is so and what the pathophysiology of heart failure and diabetes is, to put it in a nutshell, we all know that pathophysiologically in diabetes, what you have is hyperglycemia, insulin resistance, and hyperinsulinemia. And this triad which is there is responsible for several metabolic problems. For example, you have inflammation, dyslipidemia, and endothelial dysfunction because of this triad of metabolic abnormalities, which of course predisposes to coronary artery disease, and that can lead to ischemic cardiomyopathy, and this can lead in turn to heart failure. Also, there are other mechanisms by which diabetes can predispose to heart failure, and that is cardiomyocyte hypertrophy or LV hypertrophy, which can again lead to diabetic cardiomyopathy leading to heart failure. Also, you can have the renin-angiotensin system to get activated, which in turn leads to this cascade. Also, you have autonomic dysfunction. There could be disordered calcium handling, formation of advanced glycation end products, and all of these together contribute towards diabetic cardiomyopathy leading to heart failure. Therefore, this triad of hyperglycemia, insulin resistance, and hyperinsulinemia that often accompanies diabetes triggers a cascade of deleterious effects that contribute to the development of heart failure in diabetes. Therefore, not surprisingly, the risk of developing heart failure because of all these events is at least twice that of non-diabetic counterparts. And then you have so many therapies nowadays. And nowadays, apart from reducing the blood sugar, you also talk of pleiotropic effects. You would always want an anti-diabetic agent to do more than just reducing the blood sugars. And that is why you have a plethora of agents today which can do that. And different anti-diabetic drugs act through different pathways and give you different effects. So you have the biguanides, the sulfonylureas, the TZDs, etc. You have the whole list of them that are helpful in diabetes mellitus, and they are going to act through various mechanisms such as the liver, the pancreas, the kidneys, adipose tissue, the skeletal muscle, etc. And with all of this, they have variable effects on the propensity to cause heart failure as well. So these are the different ways in which you could modulate this particular function by giving an altered myocardial substrate metabolism, mitochondrial bioenergetics, playing around with the oxidative stress and the lipotoxicity, reducing inflammation, endoplasmic reticulum stress, etc. So these are all the different areas in which the different drugs can act and bring about pleiotropic effects in a bid to reduce the heart failure problem in type 2 diabetes. Now, coming to the other end of the spectrum, and that is the HbA1c. We all know that the hemoglobin A1C is the parameter that we use to assess the glycemic control of a person. Most clinical trials, or rather almost all the clinical trials up until now, use this as the goalpost. And HbA1c is important for us, and all our guidelines tell us what the HbA1c should be like. Now, in the latest ADA and EASD guidelines, and in many of the other guidelines also in the recent past, rather than having a fixed goalpost, the goalpost changes based on several parameters, and there could be patient factors, there could be cost factors, and many more. For example, if a person is expected to live long and has got stage A, B, or C heart failure, no serious comorbidities, no serious diabetes complications, and that person can have a 6.5%. You can have a target of 6.5%. On the other hand, when you have somebody who has a limited life expectancy and has got organ damage and so many other comorbidities, in such patients, your goalpost is different and it could be as high as 8.5%. So a patient's clinical and functional status, self-management capacity, the social support, the hypoglycemia risks, the costs, etc., all of these are going to matter when you are going to decide what the target A1C should be for a particular patient. Now comes the role of dapagliflozin in patients with heart failure. You have the famous DAPA-HF study, and you will have insights from that study into this. This was a seminal study in which you had more than 4,500 patients with an NYHA class 2, 3, or 4 heart failure and an ejection fraction of less than 40. And you can see here that there is a remarkable risk reduction. In fact, there is a 26% relative risk reduction and a 4.9% absolute risk reduction, which is very, very good. This is the hazards ratio and confidence interval, which is so very reassuring. And you can see that right from the beginning, there is a separation of the lines. And all across, this is the hazards ratio that you have. And this study has very elegantly demonstrated that dapagliflozin demonstrates a lower risk of worsening heart failure or death from CV causes and better symptom scores irrespective of diabetes status. Now, this is a very important thing for us to understand, that this particular study had patients who did not have diabetes. So this drug, which was originally meant for as an anti-diabetic agent, is now studied in the DAPA-HF trial, where they had a population of heart failure patients that did not have diabetes. And even in them, this same benefit was seen. And that is why it is said that the relative risk reduction with this drug for heart failure is irrespective of the glycemic status, which is very, very important and one of the important outcomes from this study. So the key messages from this presentation would be that we know that women with diabetes are at greater risk of developing heart failure than men. Hyperglycemia triggers mechanisms of heart failure in diabetes patients. I've already shown you the mechanisms by which this can happen. Glucose lowering therapies showing effects beyond glycemic control and modulating heart failure outcomes should be preferred in heart failure patients with diabetes mellitus. Also, the A1C goal should be individualized in patients with heart failure and diabetes. And regardless of the prevalence or absence of diabetes, patients with heart failure and a decreased ejection fraction who receive dapagliflozin have a lesser chance of worsening heart failure or death from cardiovascular causes. So all in all, this is a drug that has been studied very well, and it has been shown to reduce the risk of heart failure, which is very prevalent in diabetes individuals. And it has got the pleiotropic effects of reducing glycemia or reducing the blood sugars, as well as reducing the risk of worsening heart failure. Thank you.
Thank you so much, Dr. Despande, for your insights into this subject. And thank you for taking out your valuable time and being with us. I'm sure all of us are going to go back wiser and use this knowledge into our clinical practice. And just as a quick reminder that this program has been made possible in partnership with COE Equila, and watch out this space for more such enlightening and engaging videos. So thank you once again for your time.
Thank you. Thank you so much, Dr. Bhattacharya. Thank you.